So to start today, Renu Khanna, co-director of the Society for Health Alternatives, is going to take the floor. She is member of the advisory committee of WHO, and today she's going to give us an update on equity and gender issues.
Thank you very, very much. It's a real privilege for me to be here talking to you about gender and health. And it's a great opportunity for me to learn about digital health and gender equity in digital health with some of you who I recognize as global leaders in the area of gender and health. So I have 15 minutes, and I'm going to request you to warn me when my time is about to get up. The outline of what I'm going to speak about today is, as you can see, what is gender, how it affects health, what are some of the gender issues in health systems, and some reflections from my own practice from a community-based organization on what the potentials for digital health can be and what are some of the concerns. So, gender means different things to different people. For some, there is no difference between gender and sex. For many, it is to do with women and women's empowerment. And for others, it may be about gender identity, sexual orientation, or sexuality. However, gender and sex are different. While sex is biological and assigned at birth on the basis of our sexual and reproductive organs, gender is socially constructed. It is society that defines what it means to be a man or a woman in a given context, at a given time, in a given place. And there are other ways of understanding gender. Gender is fundamentally relational and applies to women as well as to men, in fact, to all people in a society. It concerns all types of relationships, economic relationships, emotional relationships, as well as the power that resides in these relationships. So gender is essentially, for me, about power relations, and that is something that we have to keep at the center of our analysis. Gender is also intersectional. Not all women are disadvantaged and vulnerable in the same way. Not all men are privileged in the same way. A woman professor, for instance, in a university in the United States has a very different set of privileges and vulnerabilities as compared to an indigenous woman, let's say, in Nepal. So, gender is structural. It works as a system. It is built on our reproductive bodies through social beliefs, gender norms for behavior, sexual division of labor, different activities and tasks for men, and activities of women are generally invisible, undervalued, and all of this provides differential access to and control over resources. And when I'm talking about resources, it's not just money or property. It's also resources like information, mobility, self-esteem, credit, control over technologies, and all of that. And it leads to differential decision-making and power. It's a system that feeds on itself, perpetuates itself. The beauty is that it can be broken. It can be broken at any of these subsystems. You can change gender norms for behavior. You can change access to and control over resources and all of that. So does gender matter in health? Both biological susceptibilities and vulnerabilities and gender affect health outcomes, and health differences for women and men exist beyond the sexual and reproductive health. Due to their biological, due to their biological and social standing, Men, women, and LGBTQI people experience differences in their health status, in their exposure to risk and vulnerability, in their access to and use of services, their experiences in the healthcare facilities, their health-seeking behavior may be different, and the result is that health and social outcomes are different with great disparities. And here are some examples. More men die in road traffic accidents than women, and this is mainly due to gender reasons. Masculinity demands that men be adventurous, risk-taking, competitive. Gender roles demand that men go out for work and leisure. Division of resources gives men greater access to vehicles and mobility. There's another example of anemia. It's higher in women because of both biological and gender reasons. Women and girls menstruate and lose blood because of menstruation and in childbirth. And the gender dimension is that women several times in many of our contexts are the last to eat and eat only leftovers in the family. Yet another example of malaria. Both men and women are equally vulnerable to malaria, except pregnant women because of their reduced immunity. Malaria in pregnancy can result in obstetric complications, including increased anemia, which causes maternal deaths. Despite all of these risks, less than 5%, and all of these known facts, less than 5% of pregnant women have access to effective interventions. Several times, sex disaggregated data is not available nor used. This chart is, I don't know whether you can read everything, you obviously can't, but it captures for me, and this is from Lancet 2018, it captures for me whatever I have been speaking about in the last few minutes. There's a pointer here. So this, for instance, oops, yeah. Okay, sorry. So I'm not going to bother to use this because I don't have mastery over technology. But over here you can see this is the sex angle where the genes, the genitalia, body features, hormones is the basis of the social production of gender through institutions like the family, the community, through structures and policies which dictate the power and the norms which are bestowed upon men and women differentially. That then leads to the gendered social position, the intersectionality that I was talking about, which is based on your race, your class, your age, your ability, your sexuality, your location. And you can see men of a certain class are right on top, and the most below are the marginalized women, younger women, for instance. And all of this then leads to gendered pathways in health, gendered pathways to health, which show up as gender differences to exposure, gendered health behaviors, gendered impact on accessing care, gender-based health systems, and gender-based health research and data collection. And all of that finally leads to gender inequities and outcomes. And this happens across the life course from childhood to old age. And another concept that's captured here is the concept of cumulative burden of all of these deprivations, which result in the embodiment of all of these disadvantages. So what are the gender issues in health systems? And here I'm looking at the 6 building blocks defined by WHO as the building blocks of health systems. Health service delivery is the first building block. Is quality and needed healthcare accessible to women and girls across their life cycle? Do trans persons and men receive the healthcare that they need? Does the organization and modes of service delivery acknowledge and respond to gender differentials in roles and responsibilities and access to resources and power? What about acceptability of health services? Timings of clinic hours, spaces, for example, for privacy and confidentiality, for adolescent health. What about provider-patient communication, especially for women from marginalized communities, for trans persons? Trans women with whom we work report facing extreme discrimination in the healthcare facilities when they try and access healthcare. Health workforce is a second building block. And is there bias-free working environment for women and men in the health workforce? Are health service providers trained in gender responsiveness? Do health systems recognize that women community health workers, unpaid care work, needs to be valued, needs to be recognized? Where are women in leadership positions? Even as principals of nursing colleges in my country, we found more men than women. Health systems, health information systems, which is what most of you are possibly concerned with. Can we readily get good quality sex disaggregated and age disaggregated data? Is it made use of at the point of data collection or only collected to be transmitted upwards? Are gender-sensitive health indicators monitored? What are the kinds of burdens of digitalization that health workers experience? Is it actually an aid and a support for their work, or does it add more burdens for their work? A recent study that I was reviewing in India was showing that the ASHA workers actually felt overburdened because they were maintaining physical records as well as digital records. And the women were saying that this is taking us away from our caring function. All that we're doing is recording. Medical products, vaccines, and technologies is another building block. Are essential medicines and devices available for women without stockouts? Medicines act differently on men and women. Are doctors taught this in the medical colleges? We saw in COVID, pregnant women were deprived of vaccines in the first phase of the pandemic because clinical trials did not include pregnant women. Health financing, because of high out-of-pocket expenses, women's health needs come last in most contexts. Households as a unit for insurance schemes means that women get excluded many times. This is something that Beatrice was talking about earlier. Many insurance packages have failed to include pregnancy and childbirth because they are not random events. So all of this are some of the issues, and this is, I'm just touching the tip of the iceberg. Leadership and governance. Are there processes and structures for participation of women in workforce like community health workers? Is there representation of women in decision-making fora? Do accountability and redressal mechanisms exist for the women service seekers? With over-medicalization and commodification of health, including women's health, resulting in increasing rates of hysterectomies and cesarean sections, we see this in my country, we argue that regulation of the private sector is really essential. I'm sure you're going to be discussing many of these issues related to gender equity in digital health. Beatrice actually spoke about some of them. There does exist a gender digital divide. Women's access to digital technologies is much less than men's. WHO is pushing for self-care for reproductive health. And while this is empowering and improving access, this is also a cause of concern for some of us in resource-poor contexts, because I feel that the state is absolving itself of its responsibility to guarantee essential health services. Ownership and privacy of data, I'm sure this is something else that you're going to be discussing in the coming 1.5 days. What does it do for women's autonomy and safety? Frontline workers' issues. I'm running out of time. And so let me just finish this. From our own work, we see that adolescent health and sexuality, use of digital devices really leads to empowerment and citizenship building. And social accountability is, real-time monitoring of services is something which our young people and women in the collectives that we work with are doing. So what is the way forward? My suggestion would be that we use the gender and health analysis frameworks, including the intersectionality lens, and the health systems building block frameworks to evolve guidelines for promoting gender equity in digital health. Thank you very much for your attention. It's been really nice to talk to all of you. Thank you.